the case, yeah, please. Yeah.
Good evening, everyone. I'm Dr. Srinathi, final year pediatric PG from Sri Balaji Medical College. Now, I'm going to present you a case on fever with multiple joint swelling. Patient Master A, male child of 8 years of age, hailing from Kuduvanjeri, whose informant is mother with good reliability, came with chief complaints of fever for past 7 days, joint pain and swelling for past 6 days, palpitation and breathlessness for past 2 days. History of presenting illness: he was apparently normal before 7 days, after which he developed a fever which was moderate grade, intermittent in nature, not associated with chills and rigors. Interfebrile period, child is dull, relieved temporarily, the fever relieved temporarily with paracetamol. He also had complaints of joint pain and swelling for past 6 days, which involved major large joints, and it was migratory in nature. Initially, it involved right knee, which lasted for 3 days, and it got reduced on its own, only to involve the left knee, which lasted for 4 days. Now, the child has pain and swelling in his left ankle joint. Pain is so severe, which increases with movements, and it is present throughout the day, not relieved on taking paracetamol over-the-counter drug, and no restriction of movement is present. No history of small joint involvement or any morning stiffness noted. Complaints of breathlessness for past 2 days, which was of class 2 by NYHA classification, and it got aggravated on doing ordinary activities and also reduced on taking rest. There was no history of any orthopnea, paroxysmal nocturnal dyspnea. He also had complaints of palpitation for past 2 days, which got aggravated on exertion and relieved on taking rest. No complaints of chest pain. And other negative histories: there was no history of generalized skin rash, no history of mood swings, emotional liability, poor scholastic performance, involuntary movements, no history of any painless swelling over the bony prominences, no complaints of epistaxis, abdominal pain, no complaints of throat pain, cold, cough, no complaints of hemoptysis, pedal edema, right upper abdominal pain, or decreased urine output, no history of petechiae, purpura, bleeding gums, no painful finger ends or any nail changes noted. No history of photosensitive rashes, oral ulcers, excessive hair loss, or any history of congestion of eyes, diarrhea, or vomiting. Shall I proceed, sir?
Want to elaborate further on the breathlessness part?
Breathlessness was grade 2, class 2, sir, by NYHA. And it got aggravated like routine, ordinary activities, that is normal, accustomed activity for his age. And he also, that got reduced on taking this. Also,
and
no
it's
history
only
of any orthopnea.
Okay. Breathlessness history is there only for the last 2 days.
Last 2 days, sir. Palpitation and breathlessness for past 2 days, sir.
Okay. And palpitations, is it, I mean, what is the duration of it?
Palpitation when he is exerting himself like on a more than ordinary activity, there is palpitation, and it is relieved on taking this. Other time he is not having, only on exertion he is having palpitation.
Okay. So palpitation on exertion is quite normal for for most of us. So it never happened at rest, right?
Yes, sir.
Was it associated with exaggeration of breathlessness?
Actually, the patient himself complained like he's having increased heart rate, like sensation more than like ordinary he used to have before. He's having a little more palpitation for past 2 days, sir.
Okay. Okay. Proceed. Yeah.
Past history: child had history of sore throat.
Why there is Srinidhi, why there is excessive hair loss that you have mentioned? What is the reason for that?
Ma'am, excessive hair loss, alopecia is to rule out SLE, arthritis, systemic lupus erythematosus, ma'am, photosensitive rashes, oral ulcers, and excessive hair loss.
Okay, what about congestion of eyes, diarrhea, and vomiting?
Conjunctivitis, like reactive arthritis, there will be conjunctivitis, ma'am, associated with diarrhea, vomiting, like dysentery. There will be past history of dysentery, vomiting, abdominal pain. That is GI abnormalities, and also congestion of eyes will be there, like Reiter syndrome. But is and also congestion of eyes to rule out uveitis, associated visual disturbances in uveitis. It will be common, which is common in JIA. Juvenile idiopathic arthritis.
Okay.
Congestion of eyes can also be seen.
Okay.
You said there is no history of small joint involvement. In what way is it related to your case?
Sir,
You said that there is no history of small joint involvement. In what way is it related to your case?
yes, we
Why is
can.
it important?
Since it is a case of polyarthritis, like it involved more than one joint, and also it involved mainly major joints. Depending on the involvement of major and like large and small joints, we can differentiate. We can rule out many differential diagnoses. Like small joint involvement is more common in juvenile idiopathic. Like it is there in juvenile idiopathic arthritis, in SLE, other connective tissue disorders, and also sickle cell crisis. All those, even reactive arthritis, post-infectious streptococcal arthritis, PSRA, all those things, there will be involvement of small joints.
Okay. So you mentioned
rheumatic, it's actually in rheumatic, there will be no involvement of small joints.
Is there a possibility of involvement of small joints in rheumatic arthritis?
Yes, ma'am. In one case, like Jacob's arthritis, there will be a deforming arthropathy of small joints.
It is a chronic one. Okay, recurrent attacks of rheumatic fever can cause chronic arthritis, which can cause deformity. That is called as Jacob's arthritis. Could you tell me the differences between PSRA and rheumatic arthritis? How can you differentiate?
PSRA, it's like it's not migratory in nature, ma'am. It's like additive. The joint pain will be there in more than one joint at the same time. Whereas in rheumatic, it's migratory in nature and also migratory and fleeting. There will be like PSRA, the latent period is more the important thing. Like after a previous history of some infection, there will be latent period of less than 1 week, the joint pain sets in. Whereas in rheumatic, there should be some more than like 2 weeks, there should be some latency for setting up of arthritis. And also in PSRA, there will be like previous history suggestive of streptococcal skin infection also. Like it can be there in mostly it can't be there in rheumatic arthritis due to rheumatic fever, and also the joint involvement is large and small joint involvement will be there in PSRA, and also it's it's mainly it is painful, and also deformity will be there, ma'am. Restriction of antalgic gait will be there, whereas there will be no residual deformity in case of rheumatic arthritis.
No, in post-streptococcal also there is not going to be any residual deformity.
Okay.
Only the latent period is varied. Yeah. Okay, after a history of sore throat, it will be very short, within 1 to 3 days. And is that correct, Dr. Richie, that they also say it is one form of manifestation of rheumatic fever also?
Some of them might go on to develop rheumatic arthritis. So it may not be that isolated joint involvement alone.
Yeah.
Most important thing is the shorter latent period and the involvement of small joints. And another thing is very good response to aspirin for rheumatic fever.
Not
PSRA. Yeah. That's the response in PRC.
So these are the basic differences. Okay.
Can you list out the cause of infectious arthritis, which also might present with joint pain?
Infections, it may be due to bacterial viral infections. Like bacterial infections, it can be due to CMV, viral infections, it can be due to EBV, like Epstein-Barr virus, cytomegalovirus, hepatitis B virus, parvovirus B19. Whereas in bacterial, it is mainly like Salmonella, Shigella, Yersinia. There can be reactive arthritis, and also like
so the etiological agents. I mean, can you group them into disease? Bacterial infections, Probably it could be septic arthritis or other causes. Infective endocarditis can involve the joint. Then?
Yes, it's like a sterile
mycobacterial infection. Mycobacterial infection can also involve the joint. Another common thing is in the older child, maybe gout also should be kept in the differential diagnosis.
Can you tell me the basic differences between rheumatic arthritis and arthritis that that is present in JIA in SOGIA? What are the cardinal differentiating features?
SOGIA is more than systemic signs will be predominantly seen along with arthritis, like rashes, salmon rashes that increases with fever, and also hepatosplenomegaly, lymphadenopathy will be there in SOGIA. And the main thing is the onset, ma'am. In SOGIA, it's 1 to 5 years, whereas in rheumatic arthritis, like it's more common after 5 years of age.
What about in JIA? In juvenile idiopathic arthritis and rheumatic arthritis, how will you differentiate?
Juvenile, actually, it can be polyarticular or oligoarticular, and it involves both small and large joints, and there will be associated eye problems like uveitis will be there, and also JIA, there is like.
What about the pain? What about the severity of pain in rheumatic arthritis and JIA?
So, in rheumatic arthritis, the pain is so severe, ma'am, that there will be excruciating pain. Even the child cannot even move the legs or touch, allow him to touch his legs. But in whereas in JIA, that pain is not so severe.
There will be stiffness. Stiffness will be more.
Stiffness, morning stiffness, gelling phenomenon. That is after some period of inactivity, there will be stiffness of joints, and also early morning stiffness will be there. And
what about the symmetrical and asymmetrical nature? Which is more symmetric? Which is asymmetrical?
Usually, asymmetric is rheumatic arthritis. Like it is migratory fleeting, since so it will be asymmetric, and this joint will be symmetric, ma'am.
What about the response to salicylates?
Salicylates or rheumatic arthritis responds dramatically to salicylates, whereas this may not respond. It has to be treated with biologicals.
Okay. So what about the deformity?
Deformity, there will be residual deformity in case of JIA, whereas there won't be like residual deformity in rheumatic.
Okay.
The relation between rheumatic arthritis and carditis.
Rheumatic arthritis, and it's inversely proportional. So, like if the severity of carditis is more, then arthritis will be less. Like arthritis is more, then carditis, the child will be having less severe carditis.
Which large joint is least commonly involved in rheumatic arthritis?
Sacroiliac joint.
Which large joint?
Joint is less commonly.
Large joint.
Least common.
Least common is
the hip joint association is pretty rare. Okay. And if you don't treat this rheumatic arthritis, do you think they will resolve by itself?
Rheumatic arthritis, actually, rheumatic arthritis will resolve on its own.
Yeah.
Sir.
Yes.
Resolve on its own after.
What is the only thing that doesn't resolve without treatment? All others will dissolve or resolve.
Carditis.
Carditis is the only thing that doesn't resolve without treatment. Okay.
So, what is the importance of this in involuntary movements you have mentioned?
Involuntary, since we are more in the favor of rheumatic etiology, like we have to rule out any neurological involvement in the form of chorea, involuntary movements, which will be common, which will be a major criteria for diagnosing rheumatic fever. So I have ruled out emotional.
So what is the specialty of rheumatic chorea?
Rheumatic chorea, usually if it has a delayed onset, like the latency between that onset of infection and the chorea, maybe 1 to 6 months. It's not. It's a
longer latent period.
Longer latent period.
So it manifests late. like more than 1 month duration.
Should it fulfill the criteria, or it is not necessary?
Even sometimes if there is even without Jones criteria cannot be taken into account in some cases. In that one of it is rheumatic chorea, synonym chorea.
Can you tell me some other thing where it need not fill the Jones criteria? Some other manifestation?
Like alone chorea, or if there is recurrence of rheumatic fever in highly prevalent high endemic areas,
okay.
And also if there is
what other PGs? What is the one more thing? Indolent or subclinical carditis. Okay. So what do you mean by that?
Clinically, it is not.
We find it in echo, and it is not clinically. There are no clinical features. We find it also in echo.
Tell me some features of carditis in echo. Is there any cutoff?
Jet velocity more than 2 centimeters for mitral regurgitation, and more than 1 centimeter for aortic regurgitation. Then peak velocity more than 3 meters per second, and it should be seen in 2 views.
Okay. So somebody has asked regarding the percentage of all the manifestations, major manifestations in rheumatic fever.
Yes, ma'am. The most common manifestation is arthritis. There will be in 75% of cases will have arthritis, and 50% will have carditis, and 10% like 10% will have chorea, and 1 to 2% will have subcutaneous nodules, and so erythema marginatum, and less than 1% will have subcutaneous nodules.
So.
What is the correlation between subcutaneous nodules and carditis?
It is like directly proportional, sir. If we found like there is subcutaneous nodule, there is more chance that the child will be having
high correlation with carditis. And you said about chorea being one of the manifestation of rheumatic fever. What are the other differential diagnoses you think of when there is chorea?
Chorea, like other differentials, like it can be seen in Huntington's chorea or Wilson's disease. It is seen in hemichorea or some hemichorea, or even in pregnancy, chorea will be there, chorea gravidorum, and
in SLE, encephalitis disorders.
Drug related.
Any drugs causing chorea?
OCPs, levodopa, dopamine antagonist.
Dopamine antagonist. Anticonvulsants.
Phenytoin can cause, I think.
Phenytoin, carbamazepine can cause chorea.
Can cause. Can you tell me, elaborate on chorea?
Definition, chorea, like yeah.
Where is the pathology in chorea?
Chorea is semi-purposive, purposeless, like abrupt, quasi-purposive involvement of the proximal joints, which is aggravated on emotional exertion, or and also relieved on sleep. It's not.
What are the 3 cardinal features in chorea? What are the 3 things that has to be present along with the movements?
Mood swings, emotional
liability,
and poor like changes in handwriting, changes in handwriting, poor scholastic performance.
Hypotonia, emotional ability. Okay. What are the signs that you elicit in chorea?
It's mainly for hypotonia features, ma'am. Since there will be hypotonia, there will be signs like milkmaid's grip, pronata sign, like milkmaid's grip is alternating contraction and relaxation if the patient squeezes the examiner's hands, and pronata sign is on rising the hands above the shoulder level. He'll be like pronating both the upper limbs outwards, facing outwards, And also there will be jack in the box tongue, like darting wormian tongue, and changes in handwriting, micrographia.
Okay.
Biaje Kanan sir has some questions.
No, see, I was just requesting that we should proceed. No, she told some history which I missed the initial 2 slides, but we are just we are discussing all the theoretical aspects of rheumatic fever and rheumatic heart disease, which can be done later after the finishing the case. Then relevant discussions can be brought in. We should proceed with the case. Can we request the presenter to summarize the case history? And then based on the case history, what was your thoughts?
Mainly like on presenting complaints.
No, again,
Summarize.
say this is this much year old boy or
Yes,
girl
sir.
as coming with this symptom and these
Okay,
things
sir.
like that. Just summarize that.
Okay, sir.
See, this is how we expect in the exam, isn't it?
8 years old, a male child, first born to non-consanguineous marriage, came with chief complaints of fever for past 7 days, with joint pain and swelling for past 6 days, along with palpitation and breathlessness for past 2 days, with past history of sore throat 2 weeks back, with no any significant family history. Like I have to go through, sir. Like I have finished only up to past history, sir.
Yeah, okay, please go ahead. That's all. Go ahead.
Yes, sir. Past history: child had history of sore throat 3 weeks back, for which home remedy was given since it was mild in severity. No history of similar complaints in the past. No history of any previous hospitalizations or drug intake. No history of skin infections in the recent past. Antenatal history: age of conception of the mother is 22 years. It was a spontaneous conception. It was a booked and immunized case. Iron and folic acid tablets were taken, and no history suggestive of any fever with rash, post-auricular lymphadenopathy in mother, and no any teratogenic drug intake or radiation exposure, or no any history suggestive of maternal medical illness. Birth history: it was a full-term normal vaginal delivery. A birth weight of 2.5 kgs, no any NICU admissions. Immunization history: child is fully immunized according to national immunization schedule. Last vaccine at 5 years of age with no any optional vaccines given. Developmental history: he was a developmentally normal child, studying in 3rd standard with good scholastic performance. Nutritional history: against an expected weight of 25 kgs, there was a gap of 40 kilocalories and 6 grams of protein. In family history, there was no any significant family history, no history of any heart disease or sudden premature death in his family. And socioeconomic history: there is a the 4 members family household, like in with per capita income of 3,250, and no any overcrowding is present with poor cross ventilation. According to modified Kupasamy scale, a family belongs to lower middle class. Contact history: no any contact with the open case of tuberculosis or COVID infection. A summary, sir: 8 years old male child, first born to non-consanguineous marriage, belonging to lower middle class family, came with complaints of fever for past 7 days, with migratory polyarthritis of major joints for past 6 days, with NYHA grade class 2 dyspnea and palpitation for past 2 days. It will be probably of acute rheumatic etiology, sir. Acute onset with rheumatic etiology. So I would like to examine cardiovascular systems.
So you don't want to examine any other system?
Mainly cardiovascular. Proceed with cardiovascular system.
Okay. Any other? Sorry, I'm having a problem here. Okay. See, am I audible? There is some issue with my net. Am I audible well?
Yes, sir, audible.
Okay, no?
Yes, sir, audible.
Right. See, I am not able to hear back from yours. See, doctor, actually, 8-year-old child, okay, comes with history of migratory polyarthritis, and with dyspnea and palpitation for the first 2 days. That should be enough as a summary, and probable acute rheumatic fever doesn't come here, isn't it? Now, maybe we can discuss the relation between fever and the dyspnea and fever and the palpitation, which your teachers already brought in, like, what are the viral causes, what are the bacterial causes, and things like that. Now, this class 2 dyspnea, but there's no dyspnea at rest. Okay, so dyspnea is cardiac or non-cardiac, and the palpitation, how are going to account? That only will be the further kind of discussion at the end of summary. So I didn't know whether you discuss these things in your history of presenting illness. So the moment you say dyspnea, you would have told some positive histories and told some negative histories to say it is more of a cardiac. For example, history of PND, yes or no, history of orthopnea, yes or no, history of syncope, history of right heart failure symptoms. All these things you would have said either yes or no, so that will tell us whether it's a left heart symptoms or right heart symptom related dyspnea. Okay, so dyspnea can be left heart related, right heart related, or these things are not there, but child is having dyspnea at rest. Many times it may not be cardiac, it be respiratory also. Isn't it? Dyspnea at rest need not be cardiac, it can be respiratory also. And if child is having fever and dyspnea at rest, that could be pneumonitis, isn't it? That need not be cardiac. So palpitation can occur both with respiratory and cardiac. So straight away we should not jump to say I would examine the cardiovascular system. Okay, that line also should be avoided. So it is enough if you say it's an 8-year-old boy came with history of fever for 7 days and then migratory polyarthritis, which looks like, okay, history wise, that we're going to discuss subsequently, because we have very small differential diagnosis or practically no differential diagnosis if you commit it as migratory polyarthritis. Okay, so this much only we can conclude based on the history. If there was bigger amount of history was there or more positive history was there, probably would have discussed, but right now there is nothing else for us to discuss based on the summary of the history. So others can kind of contribute before we can go for the clinical examination. I think, okay, you can go to the clinical examination.
General examination. Child is sick looking, febrile, not dyspneic at rest, with no signs of pallor, icterus, clubbing, cyanosis, edema, or generalized lymphadenopathy. Vitals, temperature is 100.6 degree Fahrenheit in axilla, measured with digital thermometer. Pulse rate is 150 per minute, normal rhythm, high volume with normal character. All peripheral pulses well felt, no radial or radiofemoral delay. Sleeping pulse rate measured when the child was afebrile, it's 120 beats per minute. In blood pressure, it's 110 60 mmHg in right upper limb and 120 74 mmHg in right lower limb. Measured in sitting position, like the upper limb BP was measured in sitting position, and the lower limb BP was measured tying the cuff to calf muscle. Respiratory rate 24 cycles per minute, thoraco-abdominal type, saturation 99% at room air. Anthropometry was a well-thriving child with weight of 24 kgs, which falls between, according to WHO IFP growth chart, it falls between 25th and 50th percentile. The height of 126 centimeters, which falls between 25th and 50th percentile. And as upper segment and lower segment ratio is 1:1. Arm span is 123 centimeters. And his BMI is 15.12 kilograms per meter square, which falls between 25th and 50th percentile. Head to toe examination. Head shape and size is normal. Hair normal. There is no any scarring alopecia. Face, no dysmorphic face is seen. Eyes normal. There is no any congestion or discharge seen. Ear, nose, throat normal with no any dental caries or oral ulcers. Neck normal, no visible pulsation seen. Chest and abdomen normal. Skin normal with no any rashes like erythema marginatum or Janvi lesions, no any skin or subcutaneous nodules seen. Nails normal with no sphincter hemorrhages. or nail pitting, no any pitting. Extremities, like musculoskeletal examination, mainly left knee joint and left ankle joint. There was warmth, tenderness, redness present. There also restriction of movement present. And genitalia normal, back and spine normal, no any peripheral signs of aortic regurgitation. I'd like to proceed with systemic examination, sir.
No,
First,
no.
I'll
Before
start
that, before that, we have to finish the general examination. Go to the previous slide. Previous slide. Previous slide. Now, next one. Yes. See, others also can question. Dr. Sharon, Dr. Kritika, and others. Just because I have entered doesn't mean you also keep quiet. No, previous slide, ma. See. Now here in the child you say sick looking and febrile. The slide keep changing. Now second line, if you take not dyspneic at rest, okay. The second line you said not dyspneic at rest, and then the respiratory rate is 24 per minute. Do you think this respiratory rate of 24 is high or normal?
For 8 years old, it's like in the normal range, sir.
No, that is okay. It's
Also,
upper limit of normal or it's mild tachypnea.
febrile due to temperature rise. There will
Exactly. So see, we are not asking you the reason. We have not come to that point. Child is circulating fever. Any febrile child will have tachypnea. Okay, any febrile child will have tachypnea and tachycardia. Okay, those two things immediately our eyes will try to look at. You have mentioned about the tachycardia. You rather than telling not dyspneic at rest, because dyspnea is what? Painful or difficulty in respiration, isn't it? But there is tachypnea, no? So that line could have been removed and you would have simply said child is tachypneic, mildly tachypneic, 24 per minute. Okay. Thereafter, no parallel requests, these are all understood. And then you said child is febrile, child is normal rhythm. And then say pulse rate 150 per minute, normal rhythm. What is high volume and character? Before the character, nothing is mentioned. High volume should be followed by, how can be the high volume be a normal character? High volume bounding pulse, you can say non-collapsing or collapsing. Okay, high volume bounding pulse, non-collapsing. When you say non-collapsing, you are telling the examiner that I look for collapsing and it is not there. Whenever there is high volume, you should look for collapsing. If you have collapsing, we have some differential diagnosis. If you don't have collapsing, you have some other differential diagnosis. That's why it is important. If you have said that it is normal volume, normal character, then there is some other differential diagnosis. We rule out some other etiologies, isn't it? So all these things matter. Okay. So when you say it is high volume, you end up by saying non-collapsing, meaning thereby it's high volume and just simply bounding pulses. That's all. Okay. And then all peripheral pulses well felt and no radial delay, and other things are okay. And
consciousness and orientation, you said sick looking. Is the child conscious and oriented?
Yes, sir. Child is conscious and oriented, and he's a little sick looking, sir. Since he's having a running temperature, he's sick looking, but he's oriented, sir. He's not in any delirious state. He's oriented. Time, place, and person.
Yeah, anything else to add in this page? See, when it comes to blood pressure, it is right at 110/60 in the right upper limb, in the lying posture or in the sitting posture. What do you mean by clinical blood pressure measurement? Whenever we measure clinically blood pressure, it is generally sorry, there's a lot of disturbance around here. Sorry. See, when you comment about blood pressure, in the clinically, whenever we measure blood pressure, is used in the sitting position for older children and adults. By default, when we say blood pressure, we assume that it is in the sitting posture. Here, probably you took the blood pressure and the child is lying, right? So it's better to mention. So 110/60 millimeters of mercury in the right upper limb in the lying posture. Okay. Similarly, same thing. And when you measure the right lower limb blood pressure, you also should use the term whether you use the same cuff which you use for the upper limb or used a different cuff. It matters, isn't it? The right upper limb blood pressure is 110, whereas the right lower limb blood pressure is 120. Okay, it is slightly higher. That it is normal. This difference is normally expected. The femoral artery pressure, whichever you measure, is normally higher than the upper limb pressure. So here, the only addition what you could have done is the right upper limb, the lying posture. The same with the same BP cuff, I measure the right lower limb blood pressure is 120/70. Okay. If you measure the intra-arterial pressure, okay, the numbers may be different, isn't it? This much of difference will not be there when you measure the intra-arterial pressure. Suppose you put a radial artery line and connect to the monitor and put another femoral artery and connect to the monitor. There will be some difference, but this difference will not be there. So all these are you should know. Somebody asked the questions. And then saturation normal at the room air. Okay. When you say room air, what is the FiO2? What is the FiO2? I mean, what is the amount of oxygen in the room air?
21.
Hello?
21%.
FiO2 at the room air, sir.
Yeah. What do you mean by that room air?
Hello, sir.
FiO2 is?
You said it right.
21%, right? Okay. So by the general examination, we have not kind of more educated regarding the patient's condition because of the fever. Okay. Fever can cause tachypnea, fever can cause tachycardia, fever can cause high volume pulses. So all the abnormal findings, whatever you have got, can be explained by the fever, isn't it? So because of the fever, we are not able to conclude anything on the heart disease right now. You got my point. Had the fever been not there, and you had told about this tachycardia, you had told about this tachypnea and other things, then there could have been some discussion what kind of heart disease could have been or what this, that and all. Because of the presence of fever, because fever can explain the tachycardia, tachypnea and all the other things, we don't have much to discuss and patient may not have any heart disease also. All this can be explained by the fever itself. That's the discussion on this slide. Okay, next slide. Yeah, so there not much of discussion. Next slide. Yeah, like here, I don't know the routine. Are you expected to tell all these things and say normal, normal, normal? Isn't it enough if you say the abnormal things and say everything else is normal? Okay. If there is anything abnormal, say these things are abnormal. Otherwise, you can say most of there is no other significant general examination findings, because your general examination negative findings, this is not there, that is not there, should be based on your final diagnosis. Okay. Here, in your final diagnosis, if you have brought in heart disease, then you are expected to say the negative findings of heart disease, which you try to see and which were not there. Like you said, there are no peripheral signs of aortic regurgitation. There are no peripheral signs of infected endocarditis, like that. Okay. So all these no negative, proper, appropriate negative histories to be told. And other things can be in general said, rest of the system or rest of the examination is normal, rather than telling each part of the body and say it was normal. Okay, next.
Examination.
Right, okay.
To proceed with cardiovascular system, inspection, trachea appears to be in midline. Shape and symmetry of chest wall is normal. Apical impulse visualized on left.
Sorry, just 1 second, ma. 1 second, sorry to interrupt. இப்போ இதுல என்ன பிரச்சனைனா, see, we started as a case of fever, isn't it? Fever and joint pain. And whether there was cardiac involvement or not, we do not know. It was slightly tricky if you directly tell the examiner that you are going for the cardiovascular examination. I expected that you will go for the musculoskeletal system examination because you said history of fever and migratory polyarthritis, and even history itself you commented it as rheumatic fever. So I expected that your main finding will be in the musculoskeletal system, and cardiac wise there may not be anything. That's what my understanding or my expectation was, because originally the history was not for a full-fledged rheumatic heart disease. Originally the history was more for a fever and joint pain, isn't it? Yes or no? Hello. போயிடுச்சு அவங்களோட presentation போயிடுச்சோ?
In the presentation.
Right. Anyway, I hope
she's back
again. Yeah. I request that all of you should change the names to proper names. Most of the places come only as DR. I don't know how to call you now. I am ordinary doctor and கூப்பிடுறதுக்கு பதிலா பேர் இருந்தனா அந்த பேரோட சேர்த்து கூப்பிடலாம் இல்லையா? Right. Right, ma. So நான் சொல்றது புரியுது இல்லம்மா? See, நம்ம ஹிஸ்டரியில என்ன சொல்லியிருக்கோமோ, ஹிஸ்டரியில நமக்கு லீட் இருந்து at the end of history நான் வந்து probably rheumatic heart disease, mitral regurgitation எக்ஸ்பெக்ட் பண்றேன், அல்லது வந்து is probably respiratory disease, bronchiectasis, அல்லது probably இது வந்து ஒரு hemiparesis அப்படின்னு நம்ம ஹிஸ்டரி முடிச்சிருந்தோம்னா ஜெனரல் எக்ஸாமினேஷன் முடிஞ்சோடனே you have to jump to that particular system. இங்க நம்ம அப்படி வரவே இல்லையே, வந்தோமா இல்லையா?
Sorry to interrupt you, sir. I have a doubt. She said fever, migratory polyarthritis, and there was history of palpitation and dyspnea.
Yes.
So she thought it could be due to a rheumatic etiology. I think that is why she had started examining cardiovascular system. I think that, sir. I think that way.
Correct, madam. But heart disease kind of history ஒண்ணுமே இல்லையே, palpitation, dyspnea தவிர. இப்போ உதாரணத்துக்கு என்ன சொல்றேன்னா, if there were further description in the history wise, like history of PND was there, orthopnea was there, peripheral edema was there, she was tachypneic, even injection, then improved, அந்த மாதிரி ஏதாவது இருந்ததுன்னா current problem is a cardiac problem சொல்ல முடியும் இல்லையா? இப்போ see, it's very much correlatable. Polyarthritis and heart is very much correlatable. ஆனாலும் நான் என்ன சொல்ல வரேன்னா, okay, this is right, it's not saying anything wrong. I am not an examiner, I am a non-examiner examining a examinee. சரியா? இப்போ இந்த ஹிஸ்டரி at the end of history ஜெனரலா நம்ம என்ன பண்ணிருப்போம், நான் சொன்ன மாதிரி this is probably a rheumatic heart disease or acute rheumatic heart disease, acute MR, அந்த மாதிரி ஒரு டயக்னோசிஸ் வர மாதிரி ஹிஸ்டரி நம்ம உண்மையை கிடைக்கல இல்லையா? அந்த அர்த்தத்துல சொல்றேன்.
Okay, sir.
Now probably she is going to tell about cardiovascular system and then go for musculoskeletal system. Yeah. Okay, please proceed.
So, inspection, trachea appears to be in midline. Shape and symmetry of the chest wall is normal. Apical impulse visualized on left 6th intercostal space, lateral to the midclavicular line. No any precordial bulge or visible pulsations. No engorged veins, sinuses or scars. In palpation, tracheal position is confirmed. Apical impulse palpable at left 6th intercostal space, just half an inch lateral to the midclavicular line. Hyperdynamic in nature. No any palpable heart sounds. Palpable systolic thrill felt at the apex. No parasternal heat. Percussion, left heart border corresponds to apex beat, right heart border corresponds to right sternal border. Auscultation, mitral area, S1 is soft with normal S2, heard pansystolic murmur, high pitched grade 4/6, heard over the apex, best over the apex, radiating to left axilla, and it is best heard with the diaphragm of the stethoscope. And tricuspid area, S1, S2 heard, same murmur heard with less intensity. In aortic area, S1, S2 heard, same murmur heard with less intensity, and also in pulmonary area, S1 and S2 is heard. Other system examination, for abdomen, soft, no organomegaly or no any pre-fluid. Respiratory system examination, bilateral air entry present with normal vesicular breath sounds, no added sounds, work-out breathing are normal. CNS sensorium intact with no focal neurological deficit, no any meningeal signs seen.
What about musculoskeletal system?
Actually, I've told in the general examination, ma'am, about the joints.
You tell once again.
In the left knee joint and left knee joint and as well as left ankle joint, there is a warmth, tenderness, redness present. There is no any restriction of movements present. And restriction of movements is present. And also like signs of inflammation like warmth, redness present, sir.
Right. Okay. Right. See, again, you are told in that general examination, but I probably here I missed it because எல்லாமே கடகடகடன்னு வரிசையை சொல்றப்போ the importance இல்லாம மனசு skip பண்ணிடுது இல்லையா? So that's why initially thought you tell the prominent positive findings, then say the no of the other things. Here extremities should be given more importance. Okay. One important distincting feature of rheumatic fever is the amount of pain will be much higher than the amount of swelling or redness what you see. You may not have much swelling, you may not have much redness. There'll be some local tenderness, but if you ask him to get and stand, he will not be able to even bear his own weight on that particular knee joint. So the amount of tenderness is very disproportionate. Restriction of movements will be there. Yeah, these are all fine. Now go to the examination. Now, inspection wise, the only positive finding was apical impulse visually is on the left 6th intercostal space, later to the midclavicle line. Okay, so what does it mean?
Actually, left 6th intercostal space and also in the like slightly over the 5th intercostal space also, sir. It was visualized, sir. So like I like to say like the apical impulse is displaced outwards and
down and out. So what does it mean? It means there's cardiomegaly. Okay, we're not going to further. It means cardiomegaly. And in this case, generally there will be some precordial activity also. See, when the patient has definite this much of cardiomegaly, is isolatedly only the apex alone is displaced, will not be there. There will be some pericardial activity generally. It's okay. Now coming to palpation, again you have got the apical impulse palpable at the 6th intercostal space, later to the midclavicle line. Hyperdynamic in nature. What do you mean by hyperdynamic in nature?
Hyperdynamic impulse is it is an ill-sustained. It involves more than one intercostal space, and it was like volume. It signifies volume overload, sir.
Correct. So it signifies volume overload of the left ventricle. It need not be more than one intercostal space. Many times it's more than one intercostal space. On the other hand, if the apical impulse is occupying more than one intercostal space, many times it could be RV apical impulse also. Okay, many times LV apical impulse is more localized, more likely to be in one space, but it can be more than one space also. It is lifting your thumb, but it's ill-sustained. It's coming and hitting our palm, but it's ill-sustained. Okay, the ill-sustained apical impulse is hyperdynamic nature. There is volume overload and it is not pressure overload. Okay, now no palpable heart sounds. There is thrill at the apex. Okay, the term palpable systolic thrill is not correct. Thrill is the murmur what you are palpating is thrill, isn't it?
Yes, sir.
So you can simply mention that there is a systolic thrill, not here. Systolic thrill felt at the apex. Previous one. So there is a systolic thrill felt at the apex. Previous slide. Okay. So no parasternal hue, percussion is fine. Okay, next case, next slide. Now, this auscultation component, there is always some confusion. Let me again clear very much. When you say S1, it's a combination of M1 and T1, mitral and tricuspid closing sounds. The tricuspid closing sound is generally so soft that we won't listen. Practically, S1 means M1. Okay, practically S1 means M1, and hence we will hear and characterize the S1 only at mitral area. Okay, but what about S2? S2 has A2 and P2.
A2, P2.
And that is very well here and characterized at the pulmonary area. So when you say S2 is normal at mitral area, it makes no meaning. And I have discussed this with many of the teachers, but this has been the routine. So you have just presenting. So you cannot say mitral area S1 is soft and normal is 2. So mitral area S1 is, on the other hand, when you start, you can start first sound is soft. That means that S1 is soft, means M1 is soft, because T1 we hardly hear. Okay. Then when you say normal S2, I presume that you have heard the S2 all the areas and also in the pulmonary area. The A2, P2 is normally split. You are hearing the split during inspiration. You are not hearing the split during expiration. And pulmonary component of the second sound is softer than the aortic component of the second sound. This much I understand when you say normal S2. Got the point? So normal S2 is after having all these things analyzed. That is A2, P2 gap is normal. It is varying with the respiration, wider in inspiration, not wide in expiration, and P2 is softer than A. That's normal. Then you come, a pan-systolic murmur is high-pitched, grade 4/6, here at the apex and radiating to the axilla. Many times it may be radiating to the back also. Best here with the diaphragm of the stethoscope. And at times in the left leaning position, or it need not be mentioned actually, but some examiners expect there is no close relation between the two. The location of the murmur says it's mitral murmur, isn't it?
Yes, sir.
Suppose if it doesn't radiate, what do you mean? Suppose there is a murmur in the pan-systolic murmur in the mitral area, but it doesn't radiate, or radiates slightly into the axilla, but it doesn't radiate at all. Does it?
Also, a tricuspid regurgitation, or
That will be more in the left parasternal area, isn't it? So we have three differential diagnoses for pan-systolic murmur. One is tricuspid regurgitation, second is mitral regurgitation, third is
VSD.
ventricular septal defect. Okay.
VSD.
So ventricular septal defects usually well localized. Mitral regurgitation murmur radiates, but you should remember that the mitral regurgitation, is it related to the AML pathology or PML pathology? PML, posterior mitral leaflet, AML, anterior mitral leaflet. Most of the time, whether it's acquired heart disease or even many of the congenital cases, AML is more commonly affected, anterior mitral leaflet. Jet is more directed anteriorly and to the lateral. Okay, that's why you are hearing that. If the PML is the primary pathological valve lesion, the jet may be posteriorly directed and the radiation may not be here, and you will hear only the localized pan-systolic murmur. So what I'm trying to say is, even if the pan-systolic murmur at the apex is localized and not radiating, it doesn't go against mitral regurgitation. Okay, so now here you have told this is the mitral regurgitation murmur, and whenever you say it is having a thrill 4/6 murmur, okay, what's the importance? Suppose you are telling 2 or 3/6 pan-systolic murmur versus a 4/6 murmur. What difference does it make?
It is like the lesion is severe, associated with thrill, it's severe, sir. Regurgitation is severe, yes. And also
okay. Now here we are discussing with fever, joint pain, and heart disease, isn't it? So this mitral regurgitation murmur could be a soft carditis, isn't it? It could be a functional murmur, isn't it? Any fever can have a functional murmur at times. Mostly it's in pulmonary area, but very rarely we get in mitral area. Okay? So had this been only carditis, had this been some functional murmur, usually it is 2 to 3, not more than 3. If you have thrill associated, it is not just a functional mitral regurgitation, there is a structural mitral valve disease.
Pathological mitral regurgitation.
Pathologically, the mitral valve disease is there. Certainly, it is more of a rheumatic heart disease and simply not rheumatic fever. Okay. Now, so then you after mitral area, you come to tricuspid area, aortic area. So all the other areas, no additional findings other than this single murmur. Okay. You should mention whether you heard any diastolic murmur at the mitral area. If you don't hear, you should say, I didn't hear any diastolic murmur for 2 reasons. If you have heard a short diastolic murmur, then straight away you are going to commit this mitral regurgitation as a severe mitral regurgitation. Okay.
Associated with flow murmurs, so severe.
That's what I'm saying. or there could be additional mitral stenosis also.
Yes, sir.
That's also possible. So when here it's very important to say this negative finding. Negative finding is I try to look for MDM, it's not there. Okay. So here S1 soft is going against the established rheumatic heart disease. It's going in favor of the acute rheumatic fever carditis. On the other hand, 4/6 murmur is going more towards sorry, I'm telling wrong. S1 is soft both in acute rheumatic fever and also predominant mitral regurgitation. You are right. So S1 is going for both. In simple carditis also S1 will be soft. In a predominant mitral regurgitation also S1 will be soft. And there is a 4/6 murmur. It's going more in favor of severe mitral regurgitation, though we didn't get the MDM. Okay. And when you say S2 is normal, what are you trying to imply?
S2 is normal, like if there is a loud P2, like I'm selling differentials, the loud P2, there will be, if it is S2, A2 P2, loud component P2 is component in pulmonary hypertension, it will be ruling out that. And also split, if it is normal, there is no any wide split or fixed split or reverse splitting is there. Like if wide split, it rules out, it is like more common in mitral regurgitation. Regurgitation lesions, there will be wide split since it's due to, maybe it's due to early closure of A2 or delayed closure of P2. There will be delayed closure of P2 in like early closure of A2 in aortic regurgitation, and delayed closure of P2 is seen in stenosis lesions. And fixed split is seen in S2 fixed split is there will be no variation with respiration is seen in ASD. And also
So, no,
reverse
you
splitting,
are not bringing
there is
AST here. Okay, you're not bringing AST here. You are going right. You're going right. If A2 P2 is widely split, but the split will be mobile. Okay, there be lesser split in expiration and greater split.
and it will be more in the inspiration.
Okay, if it is there, it need not be there. If it is there, again, it is a point favoring severe mitral regurgitation. Okay. Now, as you said, if the S2 is loud, P2 is loud, you are going to commit pulmonary hypertension. Presence of pulmonary hypertension also has a bearing on the severity of the mitral regurgitation, and that has to be severe, isn't it?
Yes,
So
sir.
I'm just trying to bring out what other additional clinical findings you should look for when you want to commit it as severe mitral regurgitation. Had there been P2 louder, that would have been a point favoring. Had there been a wider A to P2 gap, that would have been favoring. Had there been PA pulsations, left parasternal pulsations. Can left parasternal pulsations occur with mitral regurgitation alone? The answer is yes. Okay. So the LA enlargement, left parasternal pulsation need not be because of the RV enlargement or pulmonary hypertension. That's mere mitral regurgitation itself at times can cause left parasternal pulsation. That's why when I started, I said when somebody has this much of cardiomegaly, you might be, there is a chance that there could be other precordial pulsations also. See, all these things, when we look for and we say no, that means the examiner is very happy that you try to look for all these things to complete a severe mitral regurgitation. So here, the 2 points which are favoring for severity of the mitral regurgitation, one is cardiomegaly, significant cardiomegaly. Second thing, 4/6 murmur going up to the apex or even at the back, but there is no pulmonary hypertension. Okay, this would mean that it's a relatively recent onset mitral valve disease. Had this been a recent acute or subacute mitral regurgitation, will have pulmonary hypertension. Then the body compensates, LA enlarges, the pulmonary hypertension regresses, patient becomes asymptomatic.
And then it becomes.
Then when the mitral resistance becomes significantly bad, again pulmonary hypertension sets in. Okay, so this is the sequence of happening. Okay, so mitral area only we have the finding, other areas we don't have the finding. Aortic area specifically you should say there is no murmur. Okay, it's very important because after mitral valve, the next valve affected is aortic valve, isn't it? Mitral regurgitation and then aortic regurgitation.
Aortic regurgitation.
Okay, like that. Okay. Okay, now we can go to the next slide. Dr. Sharon, Dr. Kritika, you can add on.
Was S3 present?
I couldn't hear because of that murmur, sir. It was masked by the murmur.
I think probably as a negative finding, you can include presence of S3 or absence of S3 because presence of S3 might signify significant volume overload.
Volume overload. MR will be positive, but due to the presence of murmur, I couldn't hear it separately. So.
No, you need not give the reason. You should say, I couldn't hear. That's all. That's acceptable. Okay.
Did you look for
I don't
JVP?
think JVP, yeah.
JVP? Did you see? Did you look for the JVP?
Yes, sir. JVP is not elevated. It's it's 6 centimeters of water, sir. It's not elevated, sir. JVP normal.
Yes, when JVP is not elevated, better not to mention any number and all. That means you are not able to see the jugular venous pulse or the waves, isn't it? So better not to mention it. Only when it is elevated, then you are supposed to tell about the numbers and other things. Okay. So
I think JVP in the 45-degree position more than 2.5 centimeters is abnormal, isn't it?
Sir, excuse me.
Hello.
Yes, sir.
Yes, sir.
Dr.
Yes, sir. Dr. Srinivasan. Yes, sir. Good evening, sir. Please go ahead.
Yeah, good evening. Yeah, more than 2.5 centimeters above the clavicle in 45-degree position is abnormal in a child of this age. Am I correct?
Yes, sir. If you see that, you commit the number. If you don't see, then you say JVP is normal. That's all. Thereafter, you need not commit about the so-called number or height or whatever. That's what I was saying, sir. Child is sitting, no neck pulsations are seen. Now you are taking the child to 45-degree reclining position, no JVP pulse is seen, jugular venous pulse is not seen. So JVP is normal. Suppose in the sitting posture, you see some JVP elevated, it is significantly elevated. In sitting position, vertically sitting position, you don't see any JVP elevation. But when you make the child to go for 45 degrees, you are seeing JVP elevation. Then it is going to be elevated JVP, but less serious or less severe as compared to the JVP what you were seeing in the sitting position. Okay, this is a general understanding. And only when you see the wave, you should commit how much, at what height it is there from the Louis angle or whatever. And then once you say elevated, then you have to say whether it's A wave or B wave. Okay. And if you see both the waves, which is more dominant. If you don't see any of the two waves or if you are seeing only one wave, you have to mention that wave. So all these things come only when you say JVP abnormal. When you say JVP normal, that line alone is enough. Okay. And that should correspond with your other things. You know, there is no hepatomegaly, there is no period edema and things like that. Okay.
I have a question, sir. Like if there is an MDM heard in the mitral area, how to differentiate it from a flow murmur from a established heart disease? There is a possibility that it could be an indolent carditis. So the child may have an established rheumatic MS along with MR. So if there is an MDM, how to differentiate this flow murmur from a murmur that is heard in an established rheumatic mitral stenosis?
That's always going to be generally different.
Accentuation.
Pre-systolic accentuation occurring is more in favor of a structural
established heart
disease, because the flow murmur, the main component occurs during the initial rapid filling phase. Diastolic period has initial rapid filling phase and a small diastasis, and then second rapid filling phase. The second rapid filling phase is because of the atrial contractility.
And loudness of S1 and mitral area, isn't it, Kannan?
Yes, sir. Yes, sir. S1 could be louder, sir, if it is organic. Yes.
Loudness of S1 is also important along with the diastolic murmur. If you want to incriminate mitral stenosis.
Organic MDM. Yeah. If it is an organic MDM, the S1 rather than being soft will be loud. Okay. S1 will not be soft. S1 could be loud. And you could even hear the opening snap along with that. So if you hear the opening snap, S1 is loud, you are hearing a very good pre-systolic accentuation. We are going to commit it as organic mitral stenosis. If these things are not there, S1 is remaining soft, I don't have that additional opening snap. And my main diastolic component in the early part of the diastole is not extending up to the S1. Before it comes to the S1, the intensity comes down significantly. These things are more in favor of flow murmur because of mitral decoagulation per se. And again, let me tell you, these are all soft points only. Echo may show something else, but clinically, this is how we are going to commit. Our clinical assessment may not be 100% correct, but this is how we are going to commit. So if you have louder S1, if you have opening snap, if you have very well here diastolic murmur, especially the pre-systolic accentuation going up to the S1, it's more in favor of organic mitral stenosis. If these are not there, you commit it as probably again, if you have pulmonary hypertension, that goes in favor of a combined lesion, additional mitral stenosis, because pulmonary hypertension is more common with mitral stenosis than mitral regurgitation alone. Okay, that's why I brought out that point also. So absence of pulmonary hypertension and the MDM and apex, you can argue that there is no significant pulmonary hypertension. So I would like to consider this as more of a functional MDM than an organic MDM. Okay, so all these are the points. So okay.
Yes.
So other systems you said normal. Okay.
I have a doubt. You said meningeal signs. What is the correlation? Apart from this, you could have said some about chorea and things, right? So meningeal signs, how does it signify in this case?
Since to rule out any acute fever, ma'am, so meningeal irritation, if it has progressed to
I don't think that is necessary. Am I right, sir? Like meningeal signs is not necessary to be mentioned.
Yes, focal deficit is what we expect, not meningeal signs. Focal deficit is because rheumatic heart disease can have, because see here, this very important component is fever. And this fever, are we going to say this is infective endocarditis or rheumatic fever is very important. So all the points for or against favoring this or that to be mentioned. All the things about infective endocarditis or all the things about rheumatic fever. And that's going to come in our final diagnosis. If you don't have any peripheral signs or any other indication to say it as infective endocarditis, you are going to say this as rheumatic recurrence. It's not acute rheumatic fever alone, because you're going to commit it as rheumatic heart disease with a acute rheumatic recurrence. Okay. Suppose even if you are seeing the patient for the child for the first time, even if the child is presenting for the first time without any past history, but clinically you have diagnosed established rheumatic heart disease, then that means that's not the first rheumatic attack, isn't it? Child has had a rheumatic attack earlier, and this is a recurrence. This recurrence has made the child clinically symptomatic. Child was having subclinical heart disease and remaining asymptomatic. Okay, so there comes the importance. So CNS, sensorium, normal sensorium, no focal neurological deficit should be enough. The specific meningeal sign need not be mentioned.
Sir, PFC sir has asked whether we should always mention abdominojugular reflex to rule out early CCF in this case.
That's right, sir. That's right. That's correct. When you say JVP normal, if you want to further kind of thrust upon that right heart failure is not there, you should say after the JVP is normal, there is no abdominojugular reflux, FLUX, not EX. That's wrong. Some small spelling mistake. Abdominojugular reflux, REFLUX. If abdominojugular reflux also is not there, that definitely rules out right heart component of the failure. It's right. What Dr. Ramachandran was very correct. Okay, any other question here? And then if not, we can go for the final diagnosis.
Not ask about hepatic tenderness of the abdomen to rule out the congestive heart.
Hello, sir.
No, is it not important to talk about whether liver is balanced or not? Tenderness there, to know whether there is PCF or right heart.
See, I was not there during the history component, but what Sir is trying to say is that in the history itself, if you say there is no facial edema, there is no right hypochondriac tenderness, there is no abdominal distension, there is no periodic edema, or there is no swelling of the feet. That means history itself, you are telling the examiner that there are no signs or symptoms of right heart failure. The right hypochondriac pain is basically because of the enlargement of the liver. Same thing while examination, and the abdomen, rather than simply saying normal, no organomegaly or no hepatomegaly, you can say there is no tenderness over the right hypochondriac region, just to substantiate the point that there is no tender hepatomegaly. In acute heart failure, there will be tender hepatomegaly. Okay, and many times children will have elevated OTPT and elevated bilirubin also. Okay, that's because of the congestive hepatomegaly. Rather, we even give the name called congestive hepatitis because of the elevation of the OTPT also. So in the abdomen examination, you can say that as a negative finding, you can say there is no right hypochondriac tenderness, there is no hypotomegaly, there is no splenomegaly, there is no ascites like that. Yeah.
Actually, I mentioned in the history, sir.
I saw that. Yeah, I saw that. I remember that. Yeah.
One more thing I want to ask is, he has not graded the dyspnea.
She mentioned class 2, sir.
Oh,
She mentioned as class 2. I remember. Functional class 2 she mentioned. Okay, now that we have discussed, now you can go to the final diagnosis. We'll rediscuss whether our findings and other things are correlating. Go to the final diagnosis.
8 years summarizing the history. 8 years old male child, first born to non-consanguineous marriage, brought with complaints of fever for 7 days, with migratory polyarthritis for 6 days, along with breathlessness and palpitation for past 2 days, with past history of sore throat 2 weeks back. On examination, he had sleeping tachycardia with polyarthritis of left knee and ankle joints. On cardiovascular system examination, showed hyperdynamic apical impulse, which was shifted downwards with which was shifted outwards with soft S1, and pansystolic murmur of grade 4/6 with a systolic thrill best heard at the apex, with other systems being normal. Probable diagnosis of acute rheumatic fever with moderate carditis, not in congestive cardiac failure, in normal sinus rhythm, with no signs of infective endocarditis, with normal nutritional status.
Okay, the summary looks okay, but the diagnosis needs a bit rearrangement, isn't it? Now, as we discussed, because of the significant cardiomegaly and because of the thrill, it's more likely a established organic mitral regurgitation. If it is so, then you should commit it as acute rheumatic, rather it's a rheumatic heart disease with mitral regurgitation. And you haven't brought about the mitral regurgitation at all in the diagnosis. Okay, this acute rheumatic fever, yes, you can. If you want to say this is still a carditis, in the carditis, don't say it as mild or moderate or severe carditis. Any carditis which is clinically relevant is severe carditis. Okay, so you can say acute rheumatic fever with carditis, comma, severe mitral regurgitation, comma. Okay, then not in congestive heart failure, normal sinusism, everything. But I'll tell you, if the acute rheumatic fever is severe enough to cause severe mitral regurgitation, they will be invariably in failure. Most of them will be in failure unless the patient is on treatment. If the child was admitted to failure, you have given diuretics and things like that, and child is stabilized, then you can say right now child is not in failure. But otherwise, a acute rheumatic carditis causing this much of severe mitral regurgitation, invariably they will come with fever if they are presenting. On the other hand, if they already had mitral regurgitation, now it's a rheumatic recurrence, that mitral regurgitation may be well tolerated by the body. Body has accustomed, the heart has accustomed with that mitral regurgitation, and hence they need not be always in failure. Okay, so going with that point also, if you are sure that child was not in failure, that tachycardia, tachypnea was because of the fever alone, okay, I presume that's what you are telling me. If you want to give importance to the tachycardia and tachypnea, then you will call this as heart failure, isn't it? Heart failure need not be there, JVP need not be elevated, there need not be hepatomegaly, there need not be pleural edema. Pulmonary edema is a heart failure. Okay, if you want, say lung signs, you said no lung sign. That means the child is not in pulmonary edema. The child, if this is acute rheumatic fever, this much of severe mitral, usually there will be lung signs. Usually there will be some kind of tachypnea, and then you have to say this is heart failure. If you are saying it is not heart failure, and if you want to say patient is little stable, then more likely that it is a chronic mitral regurgitation. And now the currently what has occurred is a acute rheumatic recurrence. If this is correct, see whatever I am saying also kind of assumption, isn't it? If this is right, can you rearrange the diagnosis? I am saying that because of the whatever the reasons I told, it's an established rheumatic heart disease MR. Now, can you rearrange your diagnosis?
Yes, sir. Acute heart disease, probably of rheumatic heart disease with in congestive heart failure.
Before that, mitral regurgitation, rheumatic heart disease,
mitral regurgitation,
severe mitral regurgitation,
heart failure,
no pulmonary hypertension, not
no
in congestive heart failure, with rheumatic recurrence,
hypertension,
no pulmonary hypertension.
Sinus rhythm with no any signs of infective endocarditis.
with acute rheumatic recurrence. You have to bring the recurrence, no?
Yes, sir.
See, you cannot deny the fact of having fever, joint pain, isn't it?
Yes, sir.
So that means child is having rheumatic fever now, but this is not the first instance, this is a recurrence. So if you want to rearrange the diagnosis, you can say this is rheumatic heart disease, severe mitral regurgitation, no pulmonary hypertension, not in failure, in sinus rhythm, no infected endocarditis with acute rheumatic recurrence. That should be the final concluding diagnosis. If you have the second, whatever the possibility you have written also, we cannot negate. We cannot say exactly no. Just only finding what we have is a thrill. Thrill is generally more in favor of a established valvular heart disease. That's why I said, if you take away that point, your diagnosis could be fine. Acute rheumatic fever with carditis, severe mitral regurgitation, no pulmonary hypertension, no heart failure. Okay. As I said, any acute or subacute mitral regurgitation will increase the LA pressure acutely. Do you agree with me? Okay. There is no LA is not enlarged. LA cannot tolerate the mitral regurgitation. So any acute or subacute mitral regurgitation, if this is acute rheumatic fever with severe MR, is it an acute or subacute? Isn't it? It's not chronic. So this will increase the LA pressure. If it increases LA pressure, lung signs will be there.
Pulmonary hypertension signs
will be there.
Congestion will be there.
Congestion will be there, and child will be tachypneic and sick because these things are not there, isn't it? That's why I want to bring in more likely a chronic, well compensated mitral regurgitation with an acute rheumatic recurrence. This is how we have to argue. Okay, this is how we have to support our findings. And there are some comments here. Now, rheumatic fever, we say pancarditis, no, isn't it? Okay. But is it true that all are having pancarditis?
No, sir. Endocarditis is universal, sir.
Exactly.
Whereas myocarditis and pericarditis need not be there in all cases.
Exactly. Myocarditis is there in 70%, pericarditis in 30 to 50%. Okay. That is, rheumatic fever can be pancarditis, but it is not pancarditis in all. But endocarditis is universal, as you said. That's why we call that as only valvulitis. When it's only endocarditis, we call that as valvulitis only. Okay. And the so-called disproportionate tachycardia will occur if there is a muscle involvement. As I started discussing in your clinical examination, you started with fever. So that colors all the findings. Had there been no fever, but the patient was having heart rate of 120, that can be taken as a reason to say child is also having myocarditis, because there is no other evidence. Echo-wise, you cannot find the evidence of myocarditis. ECG also might not show. The persistent disproportionate tachycardia may be the only indicator of ongoing myocarditis. So what is the clinical sign for pericarditis?
Pericarditis clinical signs, chest symptom will be chest pain. Pericardial friction rub will be a sign.
Exactly. It could be there, and that could be there. So history is also localized chest pain, unlike myocardial infarction pain.
Have you ever heard a pericardial rub during your MBBS days? Just a question.
Yes, sir.
Yeah, of course, cases nowadays don't come so often, but during our days, pericardial rub is one of the important this thing finding. So you have mentioned so many no's in history as well as this thing. If it is not there, you can always mention there is no pericardial rub. Okay, as an important negative finding. That's what I wanted to mention.
Exactly. Right. Now,
if it is there, it's a sine qua non of acute rheumatic carditis.
Exactly. That if there is pericarditis, there is definitely myocarditis and endocarditis. Isolated pericarditis will not occur. Now, another one important difference between the myocarditis of rheumatic fever and the myocarditis of viral infection or other etiology is that the LV function remains normal. The left ventricular dysfunction is not a component of rheumatic fever. If you do the echo in a patient with rheumatic carditis, there could be mitral regurgitation, but there will not be so-called LV dysfunction. The dilatation of the LV depends on the mitral regurgitation. The heart failure is purely because of the valvular component. On the other hand, if the echocardiographer says there is LV dilatation and dysfunction, then you are going to think more of some other viral etiology causing myocarditis and LV dysfunction and not the acute rheumatic fever, even if you have the joint pain. Okay, so that's one important component of myocarditis. Pericarditis, there is no differentiating point between other pericarditis and acute rheumatic pericarditis. They all have the same vanishing type. It will be there, suddenly it may disappear. Like that, it will be there. Okay. So endocarditis is consistent. Again, there is one question from Dr. Ramesh. Again, the difference between the carditis, established heart disease, that's what we have been discussing. If it is only a carditis, usually it will be a 2 to 3/6 murmur. Patient will be soft, and patient will be more sicker. Patient will usually have symptoms of heart failure if it is a 3 or at least 3/6 murmur. Had this been only a short systolic murmur, even then there will be disproportionate tachycardia will be there. For a short 2/6 PSM at apex, you expect the patient to be totally sitting comfortably without any problem, but he will have tachycardia of 110, indicating that it's myocarditis. Okay, so all are relatively softer points only, that which I have already discussed. ECG will not help us. Presence of ECG changes will not make an carditis into acute or established carditis. Okay, echo wise, if you have pericardial effusion, if you have if the valve is relatively looking normal, except for some edematous changes in the valve, there is no commissural fusion, there is no thickening, there is no caudal shortening, there is no other echo evidence of chronic rheumatic heart disease. Only thing is valve is slightly thickened, and if there is murmur, if there is MR, then we will try to think more like an acute carditis induced mitral regurgitation. If the other things, whatever I mentioned is there, we say it is more of an established rheumatic heart disease, mitral regurgitation. Okay, so these are the things kind of echo and clinically. So how common is the rheumatic fever as such now? It is becoming less common. And we do see, like, whenever there is any complicated rheumatic fever, only people send to me. So whatever I am telling may not be truly representative. Only people like you in medical colleges should tell the true incidence of rheumatic fever. I come to know only when the patient has significant heart disease, which might need some intervention. Okay, otherwise I will not come to know. But as such, if you ask me how many cases of acute rheumatic fever I have been admitting per year, I can say 1 or 2 per whole year. 1 or 2 per whole year I'm admitting as acute rheumatic fever and treating. Some are only with arthritis, some with arthritis and carditis. The last rheumatic chorea which I saw was some 15 years back. I have not seen these 15 years of a typical rheumatic chorea. Okay. So it's relatively rare. Once our socioeconomic status increases, it's becoming less common, but still it is there. It is not a kind of, yesterday's disease. It's still existing disease.
At least 3-4 cases per month in ICH.
Okay, so that's a very big number. It's a very big number. Yeah.
You said sick looking. The child is sick looking. So what do you want to attribute it to? I mean, now that you're saying there is no congestive cardiac failure.
Probably high-grade fever. High-grade fever, at times child will be kind of, maybe.
Due to his current, at the time of examination, he was febrile, sir. So, and also
Then
he had
the joint
pain
pain
also. Joint pain was also there. He was
quite a debilitating joint pain. Okay, so it might be because of that.
And now that you have talked about viral myocarditis, so now that you are in Vadamalian Hospital for quite some time, especially with hand, foot, mouth disease and all, how many Coxsackie this thing you have seen, myocarditis?
Sir, somehow it is the rare, sir. I mean, definitely any patient coming with cardiac enlargement by the X-ray or features of heart failure, they call us for an echo at least. And we see maybe 1 or 2 cases per year. That's all, maybe 2 to 3 cases. My other colleagues may be seeing 1 case. And unfortunately, those patients have not been regularly investigated for Coxsackie. Somehow it is rare only. Whether we are not seeing or not, we are not having that much of. I don't remember a child.
What about COVID, this thing, cardiac involvement, only myocarditis with mitral regurgitation?
In adults, we have seen 2 cases, sir. In children, we have not seen.
Okay.
Children more, we have seen that complication only, sir.
Thank you. Thank you.
The post-COVID involvement, the MA, that only we have seen more commonly than during the acute things. Now, do we have the investigation of the check, X-ray, ECG, and echo, so that will kind of, make meaningful. All of our discussion will be made meaningful.
Investigations, we started with the basic investigations doing CBC, which showed mild leukocytosis, and urine routine was normal, and for acute phase reactants like inflammatory markers was done. ESR was 40 mm in first hour, and CRP is 4 milligram per deciliter. ASO titer is 390 international units per ml. Throat swab and blood culture was negative. Chest X-ray showed moderate degree of cardiomegaly with no any peripheral signs of pulmonary congestion, and ECG showed sinus tachycardia. And echocardiography with Doppler showed dilated mitral annulus, elongated chordae, and a moderate degree of mitral regurgitation was present with features suggestive of pathological MR. And tricuspid and aortic valve is normal with normal ejection fraction.
See now, ESR 40 just elevated, CRP is not elevated, isn't it?
And actually, CRP, according to our lab value, it's the normal is according to lab standards is less than 0.05, sir.
Oh, is it? That means okay, 4 milligram. I don't know. Anyway, but they are appearing mildly elevated. ASO elevation doesn't mean anything. I don't generally attach to ASO at all. If it is elevated, it's okay. If it is not elevated, also it's okay. It doesn't support or negate our diagnosis of acute rheumatic fever. Though it's one of the essential criteria that has its own fallacies. More likely it is elevated than not elevated. So if you take the swab of children, most of the children will turn to be positive. More likely, if you have taken the swab over a period of 4 to 7 days and if you show the elevation of the ASO titer, then it means there was a recent infection. Then single value doesn't tell us anything. The echocardiography wise, elongated chorda is a feature of chronic heart disease, isn't it? Because in acute rheumatic fever, there won't be so much of elongation immediately. But there is no other mention about other features of I expected whether they have mentioned thickening of the mitral valve, there any doming of the mitral valve, any commissural fusion, they should say yes or no. If there is no commissural fusion, they should mention no commissural fusion, no thickening, no. Meaning thereby, this is not a chronic one, this is more of an acute one like that. Do you have an echo image by any chance? Echo running image? If not, it's okay. So right now, we should not, let us not stop with this point. Now, how are you going to treat this child?
Basically, like we have come to diagnosis of rheumatic heart disease.
We have two components now. One component is acute rheumatic fever. Another component is rheumatic carditis or rheumatic heart disease with mitral regurgitation.
Recurrent rheumatic fever. So we are now, so this will start with treatment for carditis. Carditis, moderate carditis was there along with severe MR. So we give bed rest for 4 to 6 weeks, like followed by indoor ambulation for 4 to 6 weeks. Since it's a moderate to severe carditis, we'll go for bed rest for 4 to 6 weeks, and then we'll give initially we'll start with oral antibiotics, giving penicillin V 250 mg thrice daily for 10 days for eradication of any throat streptococci, and also anti-inflammatory treatment since he's also having arthritis and also carditis. We'll start directly with oral prednisolone, prednisolone 2 mg per kg per day for 2 weeks, and followed by we'll taper the dose, and we'll start while tapering the dose, we'll start with aspirin at 50 mg per kg per day. And also to prevent further recurrences, we'll give secondary prophylaxis with injection benzathine penicillin 6 lakh units every 3 weeks.
Right. How do you follow? Like, how do you say it is 2 weeks? Prednisolone 2 weeks. How did you decide that?
We'll measure the inflammatory markers levels, ESR, CRP. If it is getting normalizing, we'll start tapering the dose. Usually, it will get normalized within 2 weeks. Like in the
yes. So you should go by the acute phase reactant. CRP should become normal. Till that time, you should be aggressive. Will the prednisolone prevent the child from developing rheumatic heart disease?
No, sir. Rheumatic heart disease, it can't be prevented, sir. Only the valvulitis will be treated, sir.
The
The
current duration of
vegetation.
illness should be shortened. The current duration of illness should be shortened. The current chance of child going to failure will be prevented. But the child developing inflammation of the valves and subsequently developing rheumatic heart disease will not be prevented by the prednisolone. So there is an indication for prednisolone, there is no doubt, but that is not to prevent rheumatic heart disease, but this is to shorten the current episode of acute rheumatic carditis, whatever it is. Okay. So aspirin has to be always kind of, given so that there won't be the reappearing of the carditis. And
rebound carditis.
carditis will not be there. And benzoyl penicillin 6 lakhs every 3 weeks. Okay. What's the weight of the child?
24 kgs, sir. 24. If it is more than 27, it's 12 lakh international. 12
More
lakh
than
unit.
30 kilos, 12 lakhs, and less than that is 6.
And less than that, 6 lakhs.
Right. Now, this penicillin V 250 milligram TDS for 10 days also need not be strictly followed. I think that's okay. That's to eradicate the existing streptococcus. That also is not going to have any impact on the current illness, isn't it? That's basically to eradicate. What are the other drugs used other than penicillin for treating?
Usually, we'll also use a single dose of injection benzathine penicillin IM injection can be given, sir. Or if also given amoxicillin. If he is allergic to penicillin, we can give erythromycin, clindamycin,
Most of the see, this is one organism which has remained sensitive to the old penicillin itself. So most of the other used, as you said, the next commonly used one is erythromycin. Even for long-term prophylaxis, if somebody is not tolerating penicillin, the next drug of choice generally is erythromycin. There are even studies with once a week clarithromycin and all. Because of the recurrence was more, the acceptance was not there. Okay. Now, coming to the chat box, what's the evidence of carditis in this child? Yes, sir. Echo, I wanted some more echo findings to label it as rheumatic heart disease or only. If echo-wise, it's very clear that no signs of chronic changes are there, then we have to label this as carditis. The sleeping pulse, as I said, disproportionate increase in the heart rate will be one of the indication. As I already said initially, because the child has fever, the discussion never came here. If she had not told fever, but if she had told that heart rate is 110, then that can definitely be taken as a pointer of myocarditis or valvulitis or carditis, whatever. So another pointer, what clinically we were told, Dr. Ramachandran has rightly brought out the point is that you should continue the anti-inflammatory agents aggressively till the sleeping pulse rate becomes normal. On investigation wise, till the CRP becomes normal. Clinically, till the sleeping pulse rate becomes normal. Even if the murmur intensity also will come down. Till that time, you have to be aggressive. That means the myocarditis is getting controlled because of the treatment. So that's the explanation, sir.
So we measured sleeping heart rate in while the child was afebrile. Is it like we can take it into account, so like disproportionate?
That's what. Had the patient, if the child was afebrile and child was sleeping, you just connect the pulse oximeter probe to the hand, to the finger,
yes,
and
we
look for the
measured
pulse rate.
like that only, sir. Afebrile period while sleeping, we measured, sir.
Also, it is high, isn't it? But you never mentioned that, no?
Yes, sir. Mentioned, sir. Afebrile, bracket I've written, sir.
No, see this. Okay, I reached the bracket, but when you start with having fever, and then mention the heart rate of 150, then I will assume that is because of fever. Then you should write two separate heart rates. The current heart rate when I examined was 120 or 140. But when I examined 2 days before when the child was sleeping, this was the heart rate. Like that, you should tell two heart rates. Then only that will enter into our mind. No, our brain didn't catch that actually. So here, sleeping, your return is sleeping pulse rate afebrile 125 minutes, right? நான் சொன்ன மாதிரி இந்த ஃபீவர் வந்த உடனே அவ்வளவுதான், அது கனெக்ட் இருக்கலாம்னு அப்படியே மனசு எடுத்துடுச்சு. ரைட், கரெக்ட், யூ மென்ஷன் தேர். Anyway, it's a good methodological presentation. Thank you. Only thing is, again, that can be curtailed to the needs. All the things which we are not read, like for all pediatric cases, one need not go through the entire details of anthropometry, entire details of head-to-toe examination. In anthropometry, you can put the chart and simply say, anthropometry child is normal, not stunted on our understand. Child is within the third and finish off rather than mentioning the numbers. And like that, the less important ones you can ignore and more important.
Sometimes important things will be missed. For example, JVP, they had to ask you what is JVP.
Exactly.
So sometimes, when you bring so many negative things, I wrote to Kannan in box specifically, hotel போய் என்ன இருக்குன்னு சாப்பிடுறதுக்கு இது இல்லைன்னு சொல்லிட்டு அப்புறம் இருக்கிறத சொல்ல மாட்டாங்க. ஆனா இருக்கிறத சொல்லிட்டு தான் இல்லாத சொல்லணும்.
Correct, sir. Right, sir. So any comments from other panelists and others, sir, and Narvis, I think.
Do you plan the tapering of steroids?
She mentioned she'll start tapering after 2 weeks. That's an approximate timing.
Couldn't hear this.
How do you start tapering of steroids?
How do you taper the steroids?
Yeah, tapering steroids usually will start with 2 mg per kg per day for 2 weeks, and then we'll start tapering half the dose, like 1 mg per kg per day, and then we'll after giving for 2 weeks, we'll give another like 5 mg per day, like per day we'll taper 5 mg. Then for every 3 days we'll do like that, sir.
5 mg every 3-4 days you can start.
So per day 5 mg per day.
Inflammatory markers have become normal.
Yes.
I was told Dr. Zulfikar also joined. Sir, Dr. Zulfikar, are you around? But if he is not around, if had he been around this long, he would not
He was waiting for you. And probably after that he left. I sent a message to him.
I am there because of you.
Yeah.
But you never uttered a word, sir. How can this is
No,
this
no,
is
no,
not
no.
correct? We are going to find you.
Only we heard is rheumatic heart disease. A marvelous.
I just wanted to listen. In between, there is a problem with the cell phone. I just wanted to listen to you, see you all actually in person, and that's all.
Nice to hear your voice, sir. Though we are not seeing.
Yeah. I got the photograph also, Kannan.
Yes, sir. Yes. So we'll meet next week.
We'll be next week, correct?
Yes, sir. Right. So okay, so we'll finish with this, sir, and somebody can kind of give the final words and finish. Sir.
Yeah, can you switch off your slide? No, that slide sharing. Yeah. So actually, it's a good presentation. I think I am really surprised that Dr. Zulfikar Ahmed is so silent. Okay, he's a great teacher. And from comments from Dr. P. Ramchandra, sir, please.
Good evening, everyone. I joined a bit late, so I missed some of the initial parts. So, but whatever I could start from the examination, I could really enjoy it. There are really, as examiners and other things, we really don't know how to actually train the students, because exam is a different thing. There you get about 45 minutes to examine and present. But the clinical presentations like this, they probably examine for days together. They have all the findings, they have the echo findings, everything. But when they present the examination, the examiners expect in a slightly different way. So at least till they pass the exam. But that may not be the real situation. In the real situation, you get the inputs, you know already the previous investigations, everything. But still, you have to train yourself for the sake of exam. As Dr. Kannan was very well pointing out, how you have to argue out your diagnosis, how you have to support based on your clinical findings. That is how you have to train yourself, especially in heart disease. Your clinical findings, history, clinical findings, how they correlate with your diagnosis, you have to argue out. Actually, the cardiologist, the echo may be something different. They may come out with something new. It may not be exactly correlating with your diagnosis, but still for clinical examination, because examiners don't know anything about your echo findings and other things. They'll only clinically examine, they will expect you to make a clinical diagnosis. So that type of approach you have to learn, even though you know about the case, you know about the diagnosis, final diagnosis, you know more than the examiner, but still you have to train yourself for the sake of exam. I mean, it's a bit real and little bit not a real situation, but that's the way you have to do it till you pass the exam.
Yeah.
Thank you. I like the presentation. It is done very well by the students, and the discussion by Kannan, Richie, and Kritika, they were all very supportive. That is one thing. So actually, Dr. Kannan was not allowing any this thing, not even anything to be pointed out about the students. He said they are already mentioning it. They are really pointed that out very well. So that's really very, very encouraging for the students. Thanks, Dr. Kannan. Thank you.
Yeah, thank you, sir. Dr. Zulfikar Ahmad is there. Sir, can you comment? Dr. Zulfikar, sir. Hello? Okay, it's not. Dr. Srinivasan, sir, please.
Srinivasan has already made so many comments, so I'll keep quiet. Ramachandran பேசினதற்கு எதுவுமே கிடையாது.
சார் சார் இனிமே நீங்க தான் சார் முதல்ல பேசணும். நாங்கெல்லாம் வைபோயிடும்.
நான் நிறைய பேசிட்டேன்பா.
இல்ல சார், இருந்தாலும் நீங்க பேசுறது கேட்டா அது சந்தோஷம் சார். தேங்க்யூ சார்.
Dr. Ramesh, sir. Dr. Ramesh.
Thanks, sir. At the outset, I must congratulate Dr. PRC sir for the Academy Award. And his photograph was there also.
Thank you, sir. Thank you, thank you, sir. Thank you.
Regarding today's discussion, it was
Sir, your voice is breaking, sir. That's Ramesh, sir.
Are you able to hear now, sir?
Yeah.
எமோஷனலா அப்படி ஆயிட்டாரு. ராமச்சந்திரன் பேசுறது எமோஷனலா அதனால எமோஷனல் ஆயிடுச்சு வாய்ஸ்.
Sir, can you hear me now?
Yeah.
Okay. I want to make a few observations about students on the point of examination. Like
Sir, actually, Doctor, you told something about Dr. P. Ramachandran sir got awards. Where, sir? Anything you want to?
Kerala, he was given by the governor.
Yeah.
Yes, sir, it's not in Kerala. It is in Chennai. The Kerala governor came to Chennai. Kerala governor came here as a guest of honor.
Sir,
I already wished you.
Yes, sir. Thank you, sir.
Sir, on behalf of IAP TNSC, really congratulate, sir, and for this wonderful award, sir.
Thank you, sir. Thank you so much.
Many more opportunities for us to greet him later also. Don't worry.
VC Roy Award.
Thank you, sir. Thanks so much.
Okay, sir. And regarding the students, just nice that for don't know why others are part. And the PRC said examination you are supposed to do like you are not, you have no access to exam other than so that when I take classes for students, I exam case or a case for so that means case for what you are.
Sir, once again your voice is breaking.
Let me conclude by just saying they were using abbreviations like MMIG. These things annoy the examiners. You are supposed to say blood pressure, millimeter of mercury instead of pickle. You mean pallor, no pallor, cyanosis. Should be done by adult medical ward.
Sir, Dr. Ramesh sir, can you come to close to your mic, sir, please?
Yeah, I am close to the mic only. I don't know why. Is it okay now, sir?
Yeah, better.
Okay, only adult medicine PGs use this quickly. You are doing an elaborate head-to-foot examination. You are going to mention, when you come to the eyes, you talk about cyanosis, jaundice, pallor. When you go to the tongue, you talk about coating and other things. When you come to the neck, you talk about lymphadenopathy. Just talk points, facts, and figures instead of pickling around. And you will be pickled in the examination because once you annoy the examiner. And too many negative findings, as Dr. Kannan also was mentioning. See, you take an elaborate, it's no harm. You the same thing you take, then you edit it, what is needed and what is not needed. Ultimately, you are going to make only a few differential diagnoses. So your findings should either negative history or clinical findings should either confirm one of your differential diagnosis or eliminate one of the differential diagnosis. So with that, I conclude. It's a wonderful discussion, and hats off to.
But Ramesh show is very relevant because you have only 45 minutes in the examination, and the examination itself will take 15 minutes. And if you go on taking so many negative history, you will lose time. And many
Not
times
only
you
that,
become nervous.
examiners will fault you that you have been extra time, foul play. 45 minutes, you cannot make such an elaborate examination. That means you should try again and again. And I tell my PGs, just look at your watch and you start examining the case. Whether it's a
Exactly,
long
like
case or a short
swimmers
case.
training
Long
and
case, 45
running
minutes.
race training. We have to time it in the last year of training, third year
Yeah, last
training.
year I do, final year
Only
I did
45 minutes.
Short case only 20 minutes, long case 45 minutes. Like that, they have to train.
What
Thank
I
you.
generally kind of advise is that இது எல்லாமே கேஷில் எழுதிடலாம். அதாவது நீங்க கேஸ் பார்த்துட்டு இப்போ இவ்வளோ உட்காந்துருக்கீங்க, இவ்வளோ டன் வர வரைக்கும் உட்காந்துருக்கீங்க இல்லையா, அந்த நோலாம் எழுதிடலாம். எக்ஸாம் அப்ப சொல்லணும்னு அவசியமே கிடையாது. ஏன்னா அதெல்லாம் சொல்லலாம், நான் எழுதியிருக்கேன் சார் காமிச்சிடலாம்.
Exactly.
You are bluffing.
Correct. எழுதி வச்சிட்டு எழுதியிருக்கேன் சார், பட் ஐ தாட்
நாட் ரெலவென்ட் சொல்லணும். சில எக்ஸாம் எது எதிர்பார்ப்பாங்கன்னு தெரியாது.
For example, hair loss, meningeal signs, unnecessary. You need not talk in a.
Whatever the examiner is examining 8 candidates, 10 candidates per day. So imagine how this thing it will be.
Right. Thank you, sir.
Thank you, sir.
Yeah. Dr. Janani Madam, please. Yeah. Dr. Annamalai Vijayaravan, sir. Dr. Annamalai, sir, is there.
I have to thank Rajendran for giving opportunity to listen to such great this thing, teachings by so many senior persons. Okay, thank you.
Dr. Annamalai, sir, yeah. Sir, voice is not coming, sir. Okay, all right.
So one more point, sir. I must congratulate Dr. Kannan for his excellent clinical and basic examination, because normally modern cardiologists start from investigations, echo, ECG, X-ray, like that, color Doppler. He was emphasizing on clinical examination, basic examination of cardiovascular system. Thank you, sir.
Yeah, okay. Dr. Kritika, please. Yeah,
Sir, good evening to all the people who are present here, sir, all the esteemed panelists. We are very grateful, sir, for giving us an opportunity for a PGs to present in this August podium, sir. We got to special thanks to Dr. Kannan, sir, and Dr. Richie, who enlightened us on the basics of cardiology examination. Actually, more than PGs, I learned many things from Kannan, sir. Thank you for enlightening us, sir. Thank you so much, Rajendran, sir, for providing us this opportunity. And I thank our HOD, Sundari ma'am, also for giving me an opportunity to interact with the esteemed guests here, sir. Thank you.
Thank you. Dr. Richie. Yeah.
Congratulate the presenter for a good presentation. I think she was able to defend herself well. Sometimes you might go wrong in your clinical finding, but if you are able to defend it in your diagnosis, sometimes you might escape. So you should always know the explanation for each and every finding. Okay. I'd like to thank Kannan sir for chairing the session and helping out with the basic things. Thank you.
Yeah, sir. Final concluding remark by Dr. B.R.J. Kannan, sir.
It was really, whenever it comes to any teaching forum, generally I do enjoy. And whenever you do something which you enjoy, everybody will appreciate you. See, nothing new I told, or nothing very, very exhaustive cardiology we discuss. Basically, we try to analyze every point and how to get the maximum information from the available history and clinical discussion. And I really enjoyed participating in this meeting. Thank you for the opportunity.
Yeah, thank you, sir. On behalf of IAP TNSC, I thank Dr. B.R.J. Kannan. In spite of his busy schedule, I think he has participated our case presentation. I thank you, sir. I thank Dr. Richie and as well as Dr. Kritika to be as a moderator. I thank all the postgraduate to present the case in this scenario. I thank Dr. Srinivasan sir, Dr. P. Ramachandran sir, Dr. Ramesh sir and Dr. Janani, and as well as other Dr. Annamalai Vijayaraghavan sir, who has participated for this IAP TNSC case presentation. I thank once again all the students from Sri Balaji Medical College for this wonderful case presentation. And Dr. Tirumurugan is there? Yeah.
Kannan இருக்கும்போது திருமணம் நிச்சயமா இருப்பார்.
இருக்கேன் சார்.
Dr. Tirumurugan, yeah, please, yeah.
Good evening, sir. Actually, I was really enjoying. Actually, it was
Zulfier
rolling back the years. Where I was JR and Kannan sir was my SR. More than that, he was a mentor. I mean, he was the one. I mean, even those days, we emphasized so much on clinical cardiology and simplifying clinical, pediatrics. So I really enjoyed it. So it was a pleasure having it. And I have nothing else to say except that I'm really happy to be here. Thank you, sir.
Thank you, Tirumurugan.
Thank you, sir.
Yeah. Sir, Annamalai sir, sir.
Sir, are you able to hear me?
Yeah, now, sir, please, sir.
Thank you very much, sir, for the opportunity. It was a very useful and nice discussion by all of you, especially Dr. Kannan, Dr. Richie, and Dr. Kritika. And the PG had presented well, though as the examiners had pointed out, some negative findings were extra, but it was a very interesting case, and it made us think how to make out recurrent rheumatic fever, how to go about it. Dr. Kannan had really made a lot of new points, and it was useful for us. A very nice revision for the PGs and also for the faculty. Thank you very much, sir.
Yeah, thank you, sir. Thank you.
Thank you, all of you. Good night.
Thank you.
It's a pleasure listening to all of you.
Thank you, sir.
Dr. Ramachandran sir, once again, appreciation, sir.
Thank you, sir.